Well, welcome. Today we're going to talk about polypharmacy and deprescribing in geriatrics. My name is John Swegel and I am a professor over at the University of Iowa College of Pharmacy. And this is part of a series. You will get other talks specifically looking at deprescribing in the geriatric population, but this is sort of a general overview, and the crux to this is probably going to be more on the polypharmacy aspect of things. But I will give some tools on deprescribing and how you approach that. Conflicts of interest. I do not have any conflicts of interest as listed there. I have no financial relationships to any companies, and I will not talk about any pharmaceuticals, medical procedures, or devices that are investigational or unapproved for use by the FDA. These are the learning objectives, and you can kind of read through these on your own. I do want to highlight just a couple of things. We know polypharmacy exists, and recognizing that I think is an important aspect, and then the effects that it has on those patients. And then we'll talk about some tools today. I'll look at giving you some approaches to help with facilitating this deprescribing idea, and also look at other ways or different approaches that we can reduce unnecessary medications in the elderly. So what is meant by this medication consumption? How do people use medications? How is it defined? There are two main ways you could look at that, one of which is based on the population alone. 36% of the community-dwelling older patients are taking 5 or more medications. And then 80% of those 65 and older have 2 or more chronic conditions. If you just look at consumption, those that are 65 years of age, they consume more than 30% of the medications that are out there for prescriptions and over half of the over-the-counter medications. Now this slide is nothing new. It should not be anything that shocks anyone. It's the older you get, the more chronic conditions you have. Invariably, you're going to be using more medications and more therapies. If you look at a case, I have a case here of one of our nursing home patients, and this is an 89-year-old female that has dementia, she has COPD, atrial fibrillation, CKD, osteoporosis, heart failure, and osteoarthritis. And I want to just highlight an example of what people would perceive to be polypharmacy. This is a list of her medications. So just look at that. I don't expect you to look at the details of the medications that this patient has, but nonetheless, she has a lot. And if you think about that, if you go back and say, well, is she consuming too many medications? The short answer is, I don't know. I don't know this case well enough to say, but I do know that she's on a lot of medications. If you go back to the case, she doesn't even have diabetes. Imagine if this patient had diabetes, you could throw 3 or 4 or 5 more medications on board. And so this is what we want to address today. Not that we're inappropriately treating this patient, but I think it's important for us to understand that the medications can add up fairly quickly, and then you get cases that look like this from a medication standpoint. So what is polypharmacy? Just the general term, it typically means lots of medications, and it's not really been clearly defined. Numerically, a lot of people look at 5 or more medications as being deemed polypharmacy, but in all honesty, that's too simplistic. 5 medications, that you can be on 5 supplements over the counter. But the complexity of medications, the complexity of disease states that we have today, it doesn't make a number per se as a good definition of what is polypharmacy. You can look at it from a qualitative standpoint, and that really is what we're focusing on, and that's using multiple medications, but using them in an unnecessary manner. The downside to the term polypharmacy is that it implies that it's inappropriate. And this may or may not be the case, but a lot of people do associate polypharmacy with inappropriateness. And the intent of the medications, I believe, is to do good, but sometimes there's potential for more harm to be done than actual good. Issues to deal with in regards to polypharmacy. This is the challenge that healthcare has today. There are expectations of the healthcare system. So as providers are out there practicing, there's evidence-based practices that they're held accountable to. There are metrics within health systems. There are regulations from governing bodies, accreditation issues, and everyone's trying to meet these expectations as best they can within the system itself. Then you have family expectations. You have societal expectations. You also have colleagues. So if you're not prescribing something and your colleague sees that patient, they may say, why are you not taking care of this particular patient's problem? I honestly think, though, that everyone is trying to do what they think is best for patient care. And that may be the family that's trying to do that. That may be the nurse, it may be the physician, but everyone's trying to do what they think is right to help with patient care. Clinical guidelines, a couple of slides on clinical guidelines that I want to address. Guidelines, they tend to be very disease specific and they're driven objectively. So you can look at the blood pressure guidelines, looking at goal blood pressures, looking at goal A1C in the case of diabetes. Lipids, it kind of varies a little bit. The new lipid guidelines are pulling some numbers back in, but they are very objectively driven. And the geriatric population is not very well represented in these guidelines, in developing of these guidelines. And many times the guidelines do fail to address discontinuation of medications. They're good about how you add something on to get to that goal blood pressure or that goal A1C, but at what point in time do you start pulling back? Now that's getting better. The ADA, they have guidelines that talk about the prognosis of the patient, multiple comorbid conditions, the idea of you've had diabetes for a long period of time, and they will actually pull back on the numbers on the A1C for a goal based on some of those things. So the guidelines are getting somewhat better, but again, which medication do you stop? How do you take that targeted approach? That tends to be lacking in the guidelines. The general goal of guidelines, of course, is to improve disease-specific outcomes, looking at morbidity, mortality if they can. But you have to keep in mind with older patients, they may have outcomes that they don't really look at that are included in these guidelines. So for example, they may say that it's not a death issue. It's not like they want to live. It's just that they want to live life without burdensome symptoms. They don't want to have declines in functionality. Some people, they actually do value longevity, and they value this at any cost. They'll do anything just to keep them alive. But others prefer function. Others prefer symptom control, and so that's something to keep in mind when looking at guidelines and trying to individualize these patient care outcomes with medications. So polypharmacy itself does have some problems, and these are not new, but we know that there are adverse drug reactions that's associated with polypharmacy. There are drug-drug interactions, drug-disease interactions. Adherence will go down if you are consuming a whole bunch of medications. They can develop these things called prescribing cascades, where you're essentially adding a medication to treat an adverse effect of another medication. And of course, all of this can lead then to increased healthcare costs. I do want to talk about adverse drug reactions because this is an important aspect where numbers really matter. It's very similar to drug-drug interactions. The more medications that you have on a medication profile, the likelihood of having an adverse drug reaction and the likelihood of having a drug-drug interaction increases. The downside with the geriatric population is that they have a greater impact. Their ability to handle adverse drug reactions or side effects of medications is not quite the same as what it would be for a younger patient population. They tend to have a limited physiologic reserve, they have other comorbidities, they have dysfunctions with homeostasis, and they have age-related impairments with metabolism and elimination. These collectively then can impair the ability for a geriatric patient to function. So if you throw a medication on board that has good intention, it can have a negative impact in the geriatric population just because of the fact that their pharmacodynamic changes that happen in that population are different than what they would be in, say, a 40 or 50-year-old person. This is an interesting slide that I want you to look at, and the reason it's interesting to me is we talk about adverse drug reactions and we know about them, but what actually leads patients to the emergency department? What leads patients to becoming hospitalized as a result of an adverse drug reaction? The reason I want you to look at that is the top bullet there, looking at digoxin, warfarin, insulins, oral antiplatelets, and oral hypoglycemics. those alone are responsible for about 40% of drug-related hospitalizations. Now, if you know about geriatrics, if you know about medication use in this population, there is something called the Beers criteria, which I will touch upon briefly, but you'll get more of this later on when Dr. Reese gives his talk. But the reason I bring that up is the Beers criteria has something that they call potentially inappropriate medications. That criteria, looking at those medications, those are only responsible for about 1.2% of drug-related hospitalizations. So as you can see, medications that we use every day that have good reasons to be used, those can have a negative impact on geriatric patient population, and so we have to be very careful when using medications. It's not solely about a potentially inappropriate medication, but you have to consider some medications that have narrow therapeutic indexes like warfarin or insulins. Those are ones that can certainly have a huge impact when it comes to emergency department visits and hospitalizations. Undesirable outcomes with medications, dizziness and falls. You have reductions in cognition. You can have hospitalizations, as we just talked about. But the key thing in geriatrics that we want to keep in mind is the functional limitations. You have to think about things like urinary incontinence. You have to think about weight loss, constipation. These are all things that a lot of people take for granted, but they can have a negative impact in the geriatric population, and we don't want to add more to that by giving them medications that cause that. Anytime you have a new symptom in a geriatric population, you always need to look at the medications. Not saying that the medication is causing the new symptom, but it's something you at least should look at and think about as a potential cause. Prescribing in the elderly. I'm going to talk about a few aspects that are out there when it comes to using medications in the elderly population. And again, you will get more of this throughout this series, but as a grand overview, I'm going to talk just a little bit about this idea of multiple chronic conditions and how we make decisions for older people that have these. I'll be up front, it's not a simple process. We can't just across the board say that this patient population is treated the same regardless based on this disease state. We can't just do that. You have to look at the priorities of the patient. This is becoming more and more important because you have to work with them. What are they willing to do? What do they want out of life? What is their health trajectory, which we'll talk about here in just a bit. And look at key trade-offs, the benefits versus the harm. We do this all the time. One of the things that we think that is best for a patient is giving a medication with a benefit that might not be realized for a few years down the road. Does that still apply to a geriatric patient? Those are things you have to think about. Even though something may have little risk of harm, if the benefit is not going to be realized, then that little risk of harm is what takes precedence. And you have to look at coordination of these therapeutic trials. I'm going to talk about what the American Geriatric Society has been doing lately with these guiding principles for people with multiple chronic conditions. Well, again, I'll briefly touch upon the Beers criteria and some other tools that are out there. So health trajectory, I wish we all had a crystal ball and we could predict the future, but we can't. And so this makes it difficult when it comes to geriatrics. The ability to prognosticate is not an exact science. You may think that somebody has a long time to live, but we honestly don't know. Even if they have a chronic condition, we treat them based on what we think will happen, but again, no one knows for sure how patients will progress from a health trajectory standpoint. But I don't want you to think about health trajectory as simply being life expectancy. It's a broader concept, this idea. You have to think about cognition, you have to think about functionality, symptoms, clinical stability, the quality of life. What do these people want to get out of the remaining years that they may have left? So health trajectory is a broader concept that focuses more on the patient's well-being and their desires just as much as it does on longevity of life. So this came out, this multiple chronic conditions action framework. This was developed by the American Geriatric Society, just published this year in 2019. And they had a group of experts that was convened back in 2010. Their hope was to look at patient groups that have multiple chronic conditions that maybe don't fit a guideline-driven approach, or they don't fit the idea of end-of-life care. And so they're trying to place emphasis on aligning care based on the preferences of the patient, and also trying to minimize or avoid any unnecessary treatments. So this group, they came out with three main patient populations, and we'll talk about those three. Two of them are fairly straightforward. So for example, if you have an older patient that has few conditions and minimal functional limitations, and this is defined as their life expectancy is thought to be greater than 10 years, very few medical conditions, they're fit, they're functional, they're the healthy older people, then any decisions that are made as far as medications or treatments should be based on disease-specific guidelines. The American Geriatric Society did not come out with a specific age on which to apply these concepts. So I've seen people in their 80s, mid to late 80s, that are functional, they're fit, they're active in their community, they live alone. These are the type of people that you want to still, give them the treatments that are guideline driven. I've also seen people in their 50s and 60s that their prognosis is poor. So again, age is not the limiting factor, but you want to look at what conditions they have and what functional aspects or limitations they may have. So that's one group. The second group is this older patient that have advanced illness and they have limited life expectancy. That's defined as less than 1 to 2 years, advanced age, end-stage disease. In this patient population, decisions then are focused on symptom management and palliation. Now again, I said earlier that no one has a crystal ball, and so the idea of prognosticating who's going to live a year versus 2, I don't know. But as people get multiple chronic conditions, as their functionality declines, as their disease states advance, then think more palliative, get away from the guidelines. And so these two patient populations I think we already know about, and they're fairly straightforward. But this one, the third one, this is where this group that got together said, here's the best approach to take. So these are people that don't fit into the first two groups. They may have a 2 to 10 year life expectancy. They have increasing number or severity of conditions and some impairment of function, but they don't fit in one of those other two groups. And so the focus with this patient population is aligning the care to meet the patient needs. They're looking at health priorities of the patient. They're looking not just at the disease states, but looking at the functionality, what the patient wants. There's not one right answer for this patient population, and this is where it becomes very individualized, and the approach that one takes is different with one patient versus another, in part because the desires of one patient may be different than another. So this is a very interesting population of patients that really the American Geriatric Society wants people to focus on and target. So let's talk briefly about this concept of polypharmacy and how we approach it, how we address it. Remember I said that there are lots of things that are out there and tools that are used to address appropriate prescribing. There's a number of them out there. The most popular one is going to be the Beers criteria, which we'll briefly talk about. And then you have the start and stop criteria. And then you have online resources that can also be used. The key thing I want to address with these is that they are simply tools. They are not meant to replace clinical judgment. So when I talk about using some of these, please take them in context with the situation of the patient and don't let them supersede your judgment when it comes to making decisions regarding medications. There's also this idea of what's implicit versus explicit criteria. A lot of the tools that we use are what they call explicit, where they don't take a lot of thought. They're criterion-based, they're developed through reviews and expert opinion, and you get a list of medications that might be considered inappropriate. Versus implicit. Implicit approaches are judgment-based. They look at patient-specific information, and they're highly individualized. The downside between the explicit versus implicit criteria, this one takes time. This one is less time. But again, you have to take into account clinical judgment. And so we'll talk about a few of these. The Beers criteria is the first one. The Beers criteria has been out there for a number of years. There's been multiple versions of this. The most recent one came out in 2019. Beers is an example of explicit criteria. This was developed by a Delphi method where experts in fields of geriatrics and pharmacology, in medicine. They were sent out a survey, gave the results back, and the process went back and forth, and then they came up with this general consensus, if you will. But as I said, the most recent version was released in 2019. Updates to the most recent version, we're looking at removing medications that are no longer available. So for example, a drug like Ticlid is no longer available, or medications that were not considered to be drug-related problems, at least not significant enough to be on the list. And then they added some medications, and this is based on availability or newer information about those medications and how they would fit into the list. The goal for the Beers criteria has always been to improve care of older adults, and trying to do this by reducing exposure to potentially inappropriate medications. The key aspect with the Beers criteria: the Beers criteria is not a list of inappropriate medications. The Beers criteria is a list of potentially inappropriate medications. So there are situations, there are medications on the Beers list that do have appropriate uses even in this patient population. I'm going to give you some examples of what's out there for Beers criteria here in just a bit. But it's targeting those who are 65 and older, and they can be in multiple settings. They can be acute, they can be institutionalized, they can be in long-term care. It's not applicable to those who are in hospice or end-of-life care or palliative types of things. But they focus on three target areas. The first area is really sort of a list of medications that generally should be avoided in this patient population. They also look at a list of drug-drug or drug-disease state interactions to avoid. And they also are looking at avoidance or at least dose reduction based on renal function. Renal function in general is the most well-studied pharmacokinetic change that happens as people get older. And so this is why you find a lot of people looking at dosing and renal function and changing medications based on the renal function of the patient. Arguably, the Beers criteria is the most widely used, looking at these potentially inappropriate medication use in the geriatric population. It's not the sole criteria that's out there, but it certainly is widespread. So here are some examples of medications on the Beers list. The first generation antihistamines. The concern with these is that they have anticholinergic effects and they can have sedation, particularly hangover sedation, if these medications are taken at night for sleep. So the general recommendation is to avoid. Well, if you have an allergic reaction to something, I promise you that using a medication such as diphenhydramine or chlorpheniramine would be a reasonable option to take in this particular patient population. But don't use these medications for sleep. That's kind of where they're going with this. Megace or Magestrol is another medication that's out there on the Beers list. They generally recommend avoidance of this. Megace had been used to help with increasing weight, but it's minimally effective at that, and also can be used to increase risk of thrombotic events. Nitrofurantoin, this is an example of a medication we do use in geriatrics. One of the modifications that came out recently and has been included in the most recent Beers criteria is the idea of avoiding use in those with creatinine clearances less than 30. So the creatinine clearance here of less than 30, this is relatively new. It used to be less than 50 or 60, but we found that certainly you can still use this even down to creatinine clearances of less than or above 30. They do want to avoid long-term use because of risks for pulmonary toxicity or hepatotoxicity and peripheral neuropathy. And then you have glyburide, and another new addition, they added glimepiride to this list, looking at the higher risk of prolonged hypoglycemia in older patients. So the general recommendation is to avoid these if possible. But I agree with glyburide. I'm just not quite sure I agree with adding glimepiride to that list, but it is on there. More examples of the Beers criteria. Meperidine is not effective orally, may cause confusion, so avoid this. The only time that we ever see meperidine used anymore is in post-op shivering, and so aside from that, it should really never be used. Disopyramide is not one that you see used. Barbiturates probably are not the best options out there. I certainly understand if you have a patient that might have refractory seizures on phenobarbital. Yes, that makes sense. And then dronedarone is the drug I would not prescribe to anyone or give to anyone. I just don't find that drug to be of value. So they're all recommended to be avoided in the geriatric population. I would make the argument that most of these should be avoided in any population. The other tool that's out there is this idea of the start and stop criteria. The start criteria, these were both revised recently back in 2015. The concept with the start criteria is to target medications of omission. So the idea was that if you are not using a medication to treat something, that also is considered to be potentially inappropriate. So they developed these medications or these recommendations to add medications if you see certain conditions. I'll go through a few of these, but arguably they're looking at this idea that omission of essential medications is at least as important as potentially inappropriate agents on board. So these are examples of the START criteria. Again, they're focusing on those who are 65 years of age and older. The first one, statin therapy with documented history of coronary, cerebral, or peripheral vascular disease, unless the patient's status is end of life or the patient is greater than age 85. I think all of us would agree with this. It's not earth-shattering information, but it's certainly something that we should keep in mind. ACE inhibitors, if you have systolic heart failure or HFrEF and or documented coronary artery disease. Non-tricyclic antidepressants, this is used in the presence of persistent major depressive disorder. So the concept is that if you have a geriatric patient who is depressed, treat them, just don't use the TCA. And then folic acid supplement in patients taking methotrexate. That's recommended across the board, so you don't have to be geriatrics for you to recommend taking folic acid if you're on methotrexate. The STOPP criteria, this one is similar to Beers, and the concept is that you want to stop medications that might be considered to be inappropriate. Attempts to use a drug with a specific patient who has specific comorbidities, again revised in 2015, replacing the 2008 version. And these are examples of the STOPP criteria. Verapamil or diltiazem in those with New York Heart Association functional class 3 or 4 failure, because they may worsen the failure. I completely agree with that. We don't like seeing these medications used in those with reduced ejection fraction, and particularly those that are symptomatic with their heart failure. SSRIs, they don't recommend using those in patients that have recurrent or current significant hyponatremia because of a risk of precipitating hyponatremia. We had a patient on my service where I work that did have hyponatremia, was not on an antidepressant, but did have anxiety and depression, and we had discussed how do we best treat that, and the idea of SSRIs came up, and this actually was an issue. She has hyponatremia, and so we did not use an SSRI because of that purpose. Anticholinergic, antimuscarinic agents in patients with dementia or delirium, risk of exacerbation of cognitive dysfunction. So this isn't a specific medication, but there are quite a few medications that do have anticholinergic effects, so you have to think about that. And then metformin, if their EGFR is less than 30, because of a risk of lactic acidosis. And so these are the STOPP criteria. That last one, just in general, metformin, if your EGFR is less than 30, we don't use it. It shouldn't be used, period, regardless of age. But that is in the STOPP criteria examples. This one is an example of an implicit type of criteria. This is the Medication Appropriateness Index. This is not new. It's been out there for quite some time, actually, and it's designed really to address discontinuation of medications that otherwise would be indicated, but you're looking now at later in life. It's motivated by the idea of polypharmacy, and as I mentioned, a type of implicit criteria where the emphasis is on the patient. This does take time applying this tool and this approach, but it is certainly something that can have some value if you do have the time. The model itself has 4 main concepts to it. You look at remaining life expectancy of a patient. You look at the time until anticipated benefit of the medication, looking at the goals of care, the treatment targets that you're going after. And then they also have these elements of prescribing that you need to ask when addressing medication use. I did not include those 10 elements of prescribing, but an example of that is using a medication where there's no indication for a medication to be used. That's an example of an element where you can get rid of a medication. This is the concept of the Medication Appropriateness Index. And if you take time at this, on the far left, you see the arrows that go up and down that say less time and more time, and on the far right, palliative versus curative. The appropriateness of a medication is that middle box. And if the remaining life expectancy is declining, if the time until benefit is going to be less, if the goals of care change or the treatment targets change, that box at the bottom there of appropriate medications, it shrinks. So the less time a patient has as far as their prognosis and life expectancy, the less of a curative approach and the more of a palliative approach you take. So the appropriateness of a medication depends on those pillars of time until benefit, remaining life expectancy, goals of care, and treatment target. Again, as you can imagine, that's highly individualized. That's why this is an example of something that takes quite a bit of time if you're going to implement this in patient care settings. So the tools themselves, there is no ideal measure. More studies are going to be needed really to determine the outcome measures from these tools, and they may not be applicable for all settings, as we talked about earlier. End of life and palliative are settings where you're not going to be using these. And as I mentioned, do not let these replace clinical decision making. To me, the best approach is probably a combination of the tools. It also would involve the patient and their desires, as well as your clinical judgment. Now we're going to talk about a few approaches to fix the problem of polypharmacy. And the first thing is looking at this concept of deprescribing. What exactly is deprescribing? It's defined as a process of withdrawal of an inappropriate medication. It's a process that has supervision by a healthcare professional. And of course, the concept is managing this idea of polypharmacy and helping to improve outcomes. It's a collaborative process that looks at benefits and harms in the context of the patient goals, level of life functioning, life expectancy, values, preferences of the patient, and so on. It is individualized. Everyone is different, and the approach that you take to individuals can vary as well. Targeted reviews, there are certain areas that you might want to look at first from a therapeutic standpoint or from a medical condition standpoint, and then this concept of one drug at a time. Avoid making too many changes in a medication regimen. Now, there are exceptions to this. If there's clearly harm that is present, then yes, you need to stop. So, for example, somebody that has four blood pressure medications and they present to the emergency department and their systolic is 70 or 80, you're not going to continue those medications. You're going to stop all of them for the time being. The initial targets. Harm greatly outweighs potential benefit. This is where the tools can fit in, like the Beers criteria, the start and stop criteria. I would argue that if you have a medication that is causing harm, then you need to stop that medication regardless of the age of the patient. The intent of a medication is never to cause harm. So, but if your risk of causing harm is higher than your potential benefit, then you may want to stop that medication. No valid reason for a medication being used. Again, part of the Medication Appropriateness Index. This is really looking at, do you not have an indication for the medication? I would argue with this one is, again, not an age-specific thing. The last thing I want anyone to do is to make up an indication just so they can keep the drug on board. But if you don't have a valid reason for being on a medication, there's no reason to be on one. Duplication of therapy, again, you're trying to look at minimizing that. The medication, is it effective or ineffective? If somebody has a medication on board, again, regardless of age, that is not doing what it's supposed to be doing, stop it. Don't add on to it, stop it. Go a different route. And medications that the patient is not taking, either because of cannot afford it, they have adherence issues, whatever the case may be. Sometimes patients will actually declare that they don't want to take something. And you'll see this in the nursing home as an example. You'll have patients that refuse a medication and they may take it only a third of the time. Or in the home setting, they may refuse to take a medication. We had a patient in hospice recently who had a primary diagnosis of COPD, and the nurse asked me if the patient can stop taking some of her nebulized medications, and I asked why. I said, this is her primary diagnosis. She probably would feel better taking these. And the nurse said, well, she doesn't want to. She's not taking them now anyway. Okay, so she made the decision. She's able to function without taking the medications. So there's no reason for us to force a medication onto somebody if they don't want to take it. They have the autonomy and the ability to make some of those choices. Barriers that are out there are withdrawal effects. People are afraid that if you stop a medication, it might lead to some sort of a negative effect from withdrawal. And that's true with some medications. So you have to be somewhat selective on how you take medications away, depending on the medications that they are on. So for example, if we have somebody on a fairly high dose of an SSRI antidepressant, with the exception of fluoxetine, we're going to taper those down. We're not going to abruptly stop those. Some antihypertensives are the same way. But yet there are other medications that does not really matter. If you want to stop a calcium supplement or vitamin D, that's fine. You can just stop that medication. There's also a barrier about concern or fear of the original condition returning. And that is certainly a potential. But again, depends on what you're treating. If you're looking at hypertension and you take some of the antihypertensives away and the blood pressure goes up, that doesn't mean they're going to have symptoms from that necessarily. But there is fear about their condition returning, and I would argue that you want to focus on the functionality of the patient and try to reduce any limitations in that regard. The third bullet really is the bane of our existence. That's the lack of clear communication among all parties. This is not limited to family. We tend to think about the family doesn't know this or the patient doesn't know that, but we have problems with communication among clinicians, among ourselves. And so if everyone's not on the same page, that can cause disruption when it comes to deprescribing. Then you have some external factors as well, which I talked a little bit about these in the beginning, where you have the influence of regulatory practices, guidelines that are out there, other health professionals, and how they can certainly influence the prescribers. So methods that are out there to reduce medications. There are a number of different approaches that one can take and things that you can use. There's a geriatric medication type services. These are people that focus solely on geriatrics, and that's their area of expertise. There are computerized decision support systems that can be used. You can have multidisciplinary approaches. You can look at pharmacy, like someone like me, to help with making decisions and educating family and looking at the best approach to take from a medication standpoint. And then you have educational approaches, some of which are online, and there's some deprescribing tools that are out there. One is actually deprescribing.org that I encourage you to look at that website and play around with it and see if it serves a benefit for you. It is a patient-centered approach. I do not want you to lose sight of that. This is something that can change based on your patient, but you have to look at the condition and goals of care and have those goals changed. Has their condition progressed where it's different now than it was 5 or 10 years ago? What's the prognosis now? The patient and family desires, which we have to at least keep in mind, at least the family part of it. Risk versus benefits of the medications and the expected outcomes or prevention of events. The key thing with this is tied into the goals of care. The goals of care for today for a patient may be different than what they were 5 or 10 years ago. So your approach to treating that condition, managing things with that patient, those also should change based on where we are today and not be still focusing on where we were 10 years ago. Appropriateness of a medication. Family certainly does factor into it. Family never takes precedence over the patient. The patient desires are what we focus on the most, but family invariably is involved in some of these decisions, and they can be helpful. They can also not be helpful. We all run into that situation where you have family members that their intent, although good, their intent of coming in and helping mom or dad, it may cause disruption to a plan that has already been discussed or already in place. So education is a key part of that, and goal setting and being realistic on where the patient is moving from here on out. Consider the perceptions of the lay public, and I throw this in here because you will have patients that, let's say they have atrial fibrillation, and you have somebody who has been placed on Coumadin, and they originally were told that you're going to be going on this medication, and we're going to keep you on this medication indefinitely or for the rest of your life. And now we go in and say, you no longer need to take that medication. Well, the perception to the lay public is, so that means I'm going to die? They don't know. They don't look at the risk versus the benefit. We try to educate them on that, and it's very important to continue doing that. But you have to avoid this idea of giving up. We don't want to give the perception to the patient that we don't care about them. We're just trying to simplify medications, trying to minimize the risks of the medications, and trying to look at the quality of their life. Maybe not so much the quantity, but look at the quality and, again, that functionality aspect. That does require education, so the more education to both family and patient that you can provide, the better. Medication reconciliation, this is always something that we focus on, and the purpose of medication reconciliation really is to find out what are they actually taking. We have a list. We always have lists. We have lists of medications, and we see them in the computer, we see them in the nursing home, maybe on paper, maybe in a computer. We see them in a clinic on a computer. We have all these different lists that are out there, which invariably are inaccurate. They might have the medication at home, they might have a dosage at home, but that may not actually be what they're taking. In the community setting, we have people that use multiple pharmacies, and I do not support that. I would advocate that every patient should use one pharmacy. I do not care what pharmacy it is, but I think it would help the healthcare system if every patient used just one pharmacy. There are certain medications, specialty medications, that might cause them to go to a different location, but if we can generally get a list from one pharmacy, that can help the most. In the hospital setting, we're limited, so we try to do medication reconciliation in the hospital, but sometimes the patient may not give a good history or may not have access to the medications that they're taking from the pharmacy because it's at 2 o'clock in the morning. And medications in the hospital, they change. We do this all the time, and on my practice and in our inpatient setting, we'll change medications that people are taking. We might have formulary changes that happen. We might have new indications or changes in dosages based on patient presentation to the hospital. And we have to look at that as we do these transitions of care from the long-term care or to the long-term care facility, to the skilled nursing facility, to home, to wherever from the hospital. And then you have the nursing home setting. The nursing home setting is a little bit different. The physicians don't have day-to-day interactions with these patients. Sometimes it's every 2 months, depending on the payment source. And there's also turnover of staff in nursing homes. So the idea of medication reconciliation is to try and to get a grasp on what patients are actually taking and trying to get an accurate list so that everyone has the same list. The brown bag approach, this is something that is out there, which has been out there for quite some time. The idea is that you bring everything into the clinic, you open up the medicine cabinet, take everything out that you can, put it in a brown bag, and you bring this into the provider. It includes prescription medications, OTC products, herbs, vitamins, whatever else that they have in that medicine cabinet. And then that allows you to look at that bag full of medications to actually see what they have. It also is an opportunity to get rid of medications that are no longer needed. And the ideal time to do this, you can't do it at every visit. It's not practical to do it at every visit, but the idea, if you can do this at least maybe yearly, so that you get a feel for the medications that they actually have at home. I will tell you that patients, and I'm probably no different, if I paid a lot of money for a medication and someone told me that I no longer need to take that medication, but I still have some that are left over, I'm probably going to hang on to them. I don't need to, but I paid a lot of good money for these, and so I don't just want to throw them away. So if we can simplify medications so that patients are taking only what they need to take, and the brown bag approach is certainly one way that we can do that. The idea of this prescribing cascade, I mentioned that briefly in the beginning of this. You want to avoid it if possible. An example is using a non-steroidal to treat some pain, but that might lead then to an addition of a proton pump inhibitor like pantoprazole or omeprazole, or increase of a diuretic dose because of edema that happens from the NSAID. So that's the idea of this prescribing cascade. A therapeutic holiday. This is something that I think we sometimes forget about. So I mentioned earlier that you can stop a medication with this deprescribing, do a targeted approach. You might have a return of the condition. You might have a need to go back on the medication. That's what this idea of a therapeutic holiday is. There's nothing out there that says that you cannot restart something that you take away. And so don't forget that. Give them a break off the medication. I've seen this more than just a handful of times where you have older people that are on numerous medications and we start pulling back on those medications, and all of a sudden they say, I feel better. You probably have seen the same thing as well. So taking some of these medications away and then starting over and trying to treat based on the prognosis of the patient and what they want, what their goals are, what their focus is in life. Avoid medication misadventures. There are examples out there. So if you have somebody who is bedbound, certainly don't be putting them on bisphosphonates. Sulfonylureas in those who are not eating, that gets back to the Beers criteria about using glyburide or glimepiride and the risk of profound hypoglycemia. That's particularly true if they are not eating anymore or reducing their oral intake. Urinary incontinence medications and end-stage dementia. There's two reasons not to do this. One reason is that the anticholinergic aspect from those urinary incontinence medications that can make the cognition worse in people with dementia, but more importantly, they don't really work. There's not really a medication that you can use that's going to help with urinary incontinence in dementia patients. So that's an example of a medication misadventure that you should avoid. Coordination of care. In today's world, we practice in settings that have multiple different prongs that kind of go off of it. There are multiple disease states, and that typically means multiple providers. And so in my setting, I work in a family medicine residency program, so we are a primary care setting. We have patients that have heart conditions that go off and see a cardiologist. They have lung conditions, they go off and see a pulmonologist. They go off and see a nephrologist for their kidneys, just all the different ologists that are out there, rheumatologists because they might have lupus or they might have rheumatoid arthritis. And so we try to coordinate all of that. Well, we're not going to interrupt the prescribing of the pulmonologist for somebody who's being managed for COPD. We're not going to stop medications that the cardiologist stopped if they're going to continue going to see the cardiologist. So that's where this whole coordination comes into play, and communication about the goals of care amongst those different providers is also vitally important. So those two concepts are out there, and that is something that we should focus on and try to do a better job of working with and working through. So in conclusion, polypharmacy, it is an ongoing problem. It's something that we have had to deal with for quite some time, and in all honesty, the complexity of the medications that are out there, the guideline-driven approaches to care, we continue having more and more medications that can just get added on. So it's an ongoing problem, and it's not going away anytime soon, but I want you to think about how appropriate is that medication for that specific patient. Going back to the American Geriatric Society, looking at these patients with multiple chronic conditions, pulling patients more into the decision-making about what they want to do, what they're hoping to get out of life. That may not necessarily be longevity of life, but functionality of life, goals that they want to have. Keep reviewing the medication lists. I've seen this many, many times over in settings in the clinic, for example. What our list reads is different than what the hospital list may read, which may be different than what the nursing home list may read, which may be different than the pocket card the patient is carrying. So continually reviewing these lists of medications is vitally important. Look for medications that may cause adverse events. So if a patient comes in with a new symptom or a complaint, look at the medications. Medications might be either the cause or they might at least be aggravating the situation. And then ongoing assessment for goals of therapy, because as I said earlier, the goals of therapy can change for a patient. And so we want to make sure that what we are doing from a medication standpoint aligns with what the patient wants for their life and their remaining life expectancy. So with that, I will call it good. And thank you for your time.